medical students. I hope you all are well. My name is Dr. Russell Spieth. Thank you so much for listening to this training. This is going to be a suicide prevention training. I put my phone number down there, 216-320-9621, 216-320-9621. I put that in there. If anything comes up in this training that you would want to talk through with me, please feel free to do that. For some people, even discussing a topic around suicide prevention can bring up sort of issues that are challenging. So that number's there if you need it. I also will be meeting as a class to kind of discuss the content and what took place. So these are the objectives for the training. First, we're going to look at identifying some of the kind of the general suicide warning signs. We'll look at explaining strategies to intervene in a suicidal crisis, and then discuss relevant crisis resources and supports here at NEOMED. So a few things to think about, first of all. Some of you, is actually pretty likely that some of you listening have either experienced suicidal thoughts yourself, or have been friends, family members, peers of people who have thought about suicide or have actually died by suicide. And one thing I just kind of want to share is that it's really easy to look back, hindsight being 20/20, and saying, oh, I missed this and I missed that, or I should have done this and I should have done that. That's sort of human nature. I would encourage you just to keep in mind that I'm sure you did the best you could with the information you had at the time. And just try and kind of reassure yourself about that. I myself certainly have, first of all, I've had thoughts of suicide years ago, and people reached out to me and had the courage to help me. So I'm incredibly grateful to them. But also, I've lost friends and colleagues to suicide, and it's an incredibly challenging thing. But I think, ultimately most of us, all of us, try and do the best we can with what we know at the time. Another thing I would say is that as a psychologist, I do suicide assessments with patients all the time. I've done probably thousands at this point. I've been a clinician since 1995. But it's really different and more challenging when you're asking about suicide with a colleague or with a friend or with a family member. And so it feels different, and that's why we are doing this. One other thing is that NEOMED is really trying to adopt what is considered best practices for suicide prevention, and that's a public health approach to suicide prevention. So very much like training lay people to know how to do CPR or stop the bleed, to intervene with some kind of physical injury, just to get the person to the point where they can get the appropriate level of care. We think about suicide prevention in the same way, in that we don't have to be psychiatrists or psychologists or social workers or physicians to help someone who's in a suicidal crisis. All of us can do that and get them to the stage of care that they need to be in. Let me think. And lastly, this can seem like a downer topic for sure, and we will go over some of the research around NEOMED students and thoughts of suicide. But one thing I would say is that although it's not abnormal to have thoughts of suicide at different points in your life, it's also not the norm. And the majority of folks, as you'll see, go through medical school and don't have thoughts of suicide. So anyways, like I mentioned, we're kind of taking a public health approach to mental health and suicide prevention. And it's a comprehensive approach. So it really means everything. It means this training, I train new hires, we train staff, faculty, obviously students. So part of it is training all of us to know what to look for. And then it also involves having different points of care. So for employees, that might be helping get them connected to their employee assistance program, to counseling. To students here, it may be getting them connected to the counseling center here or to some type of outside provider. So it's really around sort of this multifaceted approach to identifying people who are at risk of suicide and helping get them to the right level of care. It also involves campus culture. It's something that we're still striving to do here at NEOMED, is promote a connected culture where we support one another as best we can, while obviously being challenged with our work-related goals. But certainly students here are all challenged academically, but nonetheless trying to challenge within a supportive environment and a connected environment. Looking at substance abuse issues, substance use disorders, and substance misuse is a major risk factor for suicide and just for mental illness or mental disorders in general, and having a variety of mental health services available to students and employees. So this was a study that, a sample survey, my goodness, October 2018, we surveyed the College of Pharmacy students and the College of Medicine students. So again, it was October 2018. We're gonna have another one of these surveys going out this coming academic year. There was about 148 folks who responded. So not the entire campus, but still a high enough rate of students that means the information is meaningful. So this was asking about, in the past 4 weeks, how many days did students have emotional or mental difficulties that hurt their academic performance? As you can see, essentially about 65% of the sample indicated that at least there was 1 or 2 days at the least of having some kind of mental distress impact academic performance. And there is quite a lot of research to suggest that, including for medical students, that engaging in activities that relieve stress and promote well-being. It can be good sleep, which I know can be hard to come by, exercise, which I know can be hard to come by, good, strong relationships with your peers can actually boost academic performance. So this is essentially depressive symptoms. This would not suggest that students actually met criteria for major depressive disorder, but it just kind of taps students' experiences with different depressive symptoms. So this is asking, over the past 2 weeks, how often have you been bothered by these depressive symptoms? And as you can see, about, it kind of varies based on symptom, but somewhere around 40 to 50% of the sample had experienced at least some days of having some type of depressive symptoms. And then these are more anxiety symptoms. So again, over the past 2 weeks, and this again, suggests that, anywhere from 30 to 50, depending on the item, of students experience some type of anxiety symptoms on at least a few days. This has to do with binge drinking. So that's drinking, asking about the past 2 weeks, how many times have you had 5 or more alcoholic drinks in a row? So that's typically how we would define a binge drinking episode. So you can see over the past 2 weeks, it was around 40, a little less than 40% of the sample it reported that they engaged in binge drinking at least on one day. And then this is the one that's really kind of most the focus of this discussion is, in the past year, did you ever seriously think about attempting suicide? And you can see just a little less than 10% of the sample reported they had serious thoughts of attempting suicide. So again, the majority of folks haven't, but there are those few who have. And this is about really trying to ensure that we do our best as a community to help that 10%. To get the appropriate care if they're having a suicidal crisis. So what is a suicide prevention gatekeeper training? Probably many of you had these at your undergraduate campus. It's pretty common in Ohio to offer suicide prevention gatekeeper trainings for students and employees. Essentially, it's a training that what you're trying to do is just increase knowledge about suicide behaviors, dispel some of the myths, and help people feel more competent to be able to intervene, to ask someone if they're having thoughts of suicide, and to help them get the appropriate care based on that response. Suicide is a really hard thing to measure. I mean, even defining whether a suicide occurred is hard to actually define. Think about Journal of American Medical Association had a really interesting article that came out in about, I think, 2017. This suggested that a lot of the overdose deaths related to opioid use disorder or opioid overdose deaths were actually intentional and not unintentional. But again, that's a hard thing to know whether or not the person intended or didn't intend. Also, think about a person who hits a tree by themselves in a car without their seatbelt on. Well, that could have been just a really high risk behavior the person engaged in, or it could have been an intentional suicide. So even defining whether a suicide occurred is incredibly challenging. And as a society in the US, we do not like to talk about suicide. We don't like to think about it. There's a lot of shame and family shame around it. So it's not discussed very openly. Even though suicide occurs much more frequently than homicide, we think a lot more about homicide than we do suicide. So a lot of this is really just trying to shine light on this issue and to help us understand that although it's not the majority of people's experience, there are many people who do have thoughts of suicide or engage in suicidal behaviors. And we would hope that we do our best to support that person and get them the help that they need. So this is not meant to be counseling or treatment. This is really about getting the person to the next step. Again, even though I'm a psychologist, if I had a colleague or a family member who was suicidal, I'm not going to be doing counseling with them for a lot of reasons. Ethically, one of the biggest. But what I would be doing is still asking if they were having thoughts of suicide, and based on their answer, trying to help them get appropriate treatment. And it's really just meant to be a hopeful intervention and positive, though it is nerve-wracking and stressful. So here's some suicide myths and facts. Myth: no one can stop a suicide. It is inevitable. It does, again, I mentioned that research on suicide is challenging for a lot of reasons. But what research exists suggests that suicide can be stopped. Maybe not for all people. There may be a subgroup of people where it is inevitable. But there is certainly a group of people who are suicidal, but once they're intervened with, wind up deciding not to die by suicide. There's lots of different research on this, including some of the evidence-based gatekeeper trainings, like Question, Persuade, Refer, which this is based on. I can't call this Question, Persuade, Refer because we have to do it virtually. But there's evidence to suggest that when people have been intervened with by someone trained in QPR, Question, Persuade, Refer, that they find it relieving and decide that they're not going to die by suicide. So essentially, at least we believe that for many people, suicide is not inevitable and that anybody could intervene to help that person. Confronting a person about suicide will only make them angry or basically kind of increase the risk of suicide. That's something that a lot of us believe. It makes sense because it's something we don't talk about very much, suicide. But again, the research suggests what we have out there suggests that people actually, when they're intervened with around thoughts of suicide, many state that it was actually very relieving for them, that they felt hopeful that someone cared enough to ask, and that it did not increase the risk of suicide. It actually decreased the risk of suicide. So generally, we would argue that it's important, if you're coming from a good place and you believe that the person's at risk, to ask them directly about suicidal intent. Only experts can prevent suicide. Definitely not. The majority of people who decide not to die by suicide didn't talk to a psychiatrist or a physician or a psychologist or social worker. They talked to a family member, a loved one, a friend, a religious leader, someone that had a personal relationship with them. So again, we're arguing from a public health perspective that this is something that's everybody's business. Suicidal people keep their plans to themselves. Certainly some people do, right? But there's also a lot of research to suggest that many people didn't keep their plan to themselves, though it might have not been obvious that what they were doing was kind of planning to kill themselves. And this is again where I would say probably some of you know people who died by suicide, and just understand that that we do the best we can with information we have, and it's a really hard thing to predict who's going to die by suicide and who it. And it's really easy to look back and say, oh yeah, they did give away their favorite guitar, or they were getting much more interested in religion or whatever, and then kind of beat yourself up. And I would just say that's unfair to yourself. But people oftentimes do communicate in some way to somebody intent, even if it's more covert, or more symbolic. We'll talk a little bit about some of that later. Those who talk about suicide don't do it. There's this, the person who cried wolf. So if they're talking about it, that means they're not going to do it. That's been very much disproven in the research, is that there are people who talk about it and even have frequent attempts, and then ultimately do die by suicide. And again, the last is just, it is a preventable kind of death, a very preventable kind of death. And any positive action may save a life. So what are some of the clues and warning signs? And this is not a comprehensive list. Human beings are incredibly interesting, obviously, probably why y'all are in medical school, and incredibly complex, and which means a lot of times we kind of do it our own way or do our own thing. So these are just some of the more common direct verbal clues. So someone really overtly saying, I've decided to kill myself, that's obviously a pretty direct verbal clue. Sometimes it's more passive, people saying things like, I wish I were dead, or I wish this would all end, or I wish I didn't wake up in the morning. That's a more passive thought of suicide, but something to check in on. I'm going to commit suicide. Again, that's very direct. I'm going to end it all. That's very direct. Sometimes people say things like, if I get kicked out of medical school, I'll kill myself. Or if I lose my job, I'll kill myself. Or if my partner leaves me, I'll kill myself. So these kind of like contingency verbal clues. So those are all things that we would check in on in a gatekeeper, with a gatekeeper mindset. More indirect. So I'm tired of life. I just can't go on. They're not directly saying they're going to kill themselves, but they're kind of alluding to it. My family would be better off without me. Everybody would be better off without me. Who cares if I'm dead anyway? I just want out. I won't be around much longer. Pretty soon you won't have to worry about me. So those are all those more indirect verbal clues that we would still encourage you to ask the person, and we'll get to the questions later, if they're having thoughts of dying by suicide. That's typically in my career, in my life, these are typically the way people say it more often, and it's very vague. So I just want out of all this pain, or people would be better off without me, or oftentimes the more common things that people would say. There's also behavioral clues. So, and oftentimes you may not know this, but if people have had a previous suicide attempt, they are at more risk to dying by suicide. People who are acquiring lethal resources to kill themselves, such as acquiring a gun or stockpiling pills. People who have co-occurring depression, moodiness, hopelessness. Though what I would say, there also seems to be a group of people who don't seem to exhibit mental health symptoms, mental disorders, never been in mental health treatment and die by suicide. But nonetheless, having a co-occurring mental disorder it puts someone at more risk. People who put their personal affairs in order. We've had over the years, students and staff all of a sudden begin to give away kind of prized possessions. They may give one thing to one person and one thing to another person. So it may not be completely obvious. But fortunately, in those situations, someone reached out, and we'll talk about where you can reach out to, and said, hey, I'm kind of concerned about such and such because they gave me their guitar and they had talked to me about how important their guitar is. Giving away prized possessions, sudden interest or disinterest in religion. Like I alluded to earlier, for some people, when they're making plans about suicide, they actually get more interested in religion, and others get less interested in religion. Drug or alcohol abuse, also any relapse after a period of recovery is a big risk factor for dying by suicide. And for many people, depression or kind of distress is manifested in anger, aggression, and irritability rather than sort of sadness or tearfulness. So that's also something to look for. And what I would say about behavioral clues is, some of us are oftentimes irritable, and others of us are oftentimes kind of happy-go-lucky, and some of us are sometimes more on the sad side of things. So really kind of what we're looking for is when someone is off their baseline. So the person who's normally fairly pleasant is all of a sudden beginning to be more irritable. Or the person who's typically kind of sad is all of a sudden like really sad and very distressed. So, we're really trying to, or isolating. So the person who's typically pretty gregarious and interactive with people is all of a sudden more isolated and on their own. So it's really kind of looking for people who all of a sudden there's been a change in their behavior. Situational clues, so being fired or being expelled from school, being dismissed from school, a recent unwanted move, a loss of any major relationship, the death of someone who's close to them, diagnosis of a serious or terminal illness, sudden unexpected loss of freedom or fear of punishments. Those are sometimes people who are maybe going to be going to jail or prison. Anticipated loss of financial security, so any major financial hit a person takes. A loss of someone who's really cherished. I put in there also like a 12-step sponsor. I've known folks who've died by suicide after a cherished sponsor died. Fear of becoming a burden to others. Those are some of the situational clues that could be a warning sign. So if you sort of, were relating to somebody and it seemed that maybe there were some of those red flags there, then you begin to think about, okay, how do I ask this person if they're having thoughts of suicide? So we would say, if in doubt, don't wait, ask the question. I would just say we've had some employees and students both who, fortunately, we have had one student die by suicide. Obviously, that's not fortunate. That was incredibly unfortunate back, I think it was 4 years ago now, before I was here. So that was incredibly sad. We've had other students and employees who have had thoughts about suicide, and sometimes they would kind of communicate something to somebody, and that person would wait a little bit, and which is, I get it, because you don't want to get someone in trouble or you don't want to overreact. But we would argue, if you're in doubt, don't wait, ask the question. If the person is reluctant to talk about it, be persistent, but be persistent in an empathic, compassionate, caring way. Obviously, talk to the person alone in a private setting. So you really want to find an opportunity to talk to that person when you had time, where you weren't in a rush, where you could do it privately, and you could be in an environment where you could discuss it freely with the person. It's also really helpful to have resources handy, so that you have phone numbers or any kind of crisis information very accessible that you can share with the person at that time, which is why on the back of your NEOMED badges, you have information about crisis resources right there. We also have them in different parts on campus. So tips for asking someone about suicide. So you can always start with like kind of getting into the conversation in a less direct way, which totally makes sense. Something like, have you been really unhappy lately? Have you been so unhappy that you're thinking about ending your life? Do you ever wish you were dead or wished you could go to sleep and never wake up? So those are some of the more kind of indirect ways of getting into the question, but it can be a really nice way to start. Then you typically would, based on how they respond, go into sort of a more direct approach. So, when people are upset as you seem to be, they sometimes consider suicide. Have you had thoughts of killing yourself? Those people who study research argue that's a really nice normalizing question, because you're kind of implied in that question is that sometimes people think about suicide when they're going through very hard times like you are. I wonder if you're thinking about suicide. Are you thinking about killing yourself? So those are the more direct questions, again, that we would encourage you to ask if you believed that the person you were associating with had some of those red flags. And if you can't ask the question, and I get that too, the idea is to find someone who can, and we'll give you some ideas of who that can be. First of all, it could be another student. If we're talking about your family, it could be a family member. It could be someone in your social network who knows that person. But it could also be, if it's related to a NEOMED person, employee or student, it could be a few of our avenues here. So we'll get to those in a little bit. A question to avoid is something like, you're not suicidal, are you? If you're suicidal, that's a very hard question to answer yes, because it almost, you got to climb quite a hill, because the assumption is, why would you be? So really, when you're asking this question, you want to make it as easy as possible for the person to say, yes, I am. And that question is just not going to do that. And by the way, when you're doing your clinical skills assessments and assessing people for suicide in your psychiatric rotations, eventually you're not going to want to ask that question either. How to encourage someone to stay alive. So, you're asking the question and the person's saying, yeah, I have been having thoughts of killing myself. I don't know if I would ever act on it, but I'm thinking about it, right? Which is a pretty common thing that you may hear. You really want to listen to the problem and give them your full attention. This is where you really want to be empathic and just listen and let them talk and provide compassion. When you're talking to them, just kind of the idea that remembering that suicide is not the problem, it's a solution to a perceived problem that's insolvable. So someone who feels hopeless, or someone who's in significant pain, suicide is the way that they're trying to deal with that hopelessness or that sense of pain. Do not rush to judgment. Offer hope in any form you can. Be really affirming. Things like, it's so much better having you around. I love the way that you taught me about this, or I really like how you're able to see the humor in things. So being very specific and affirming about the benefits of having them around has on your life. And offering hope, such as, people go through this sometimes, and oftentimes people feel so much better when they get the right kind of help. Let's work on getting you the right kind of help. So how to encourage someone to stay alive. So once again, you got that scenario where the person's saying, I'm having thoughts about it. I don't know if I'd ever act on it. Then you could ask something like, will you go and get help with me? Will you let me get you help? Will you promise not to kill yourself until we found some help? So I'd say, first of all, will you go get help with me is one of the strongest things that you can offer. And again, there is research to back that up in terms of the effectiveness of these type of trainings. People who are in a suicidal crisis, there are some whom really benefit from having the person go with them. So literally walking with them to the counseling center, or if you're in the community, going with them to the hospital. Having basically a companion can really help people. So that would be, your kind of most robust intervention, but not everybody's going to go for that, right? So you have to do what the person's willing to do. So then the second option down would be, okay, will you let me help you get help? So that might be making a phone call with them, or giving them some phone numbers of some resources. This third option, will you promise me not to kill yourself until we found some help, is another option for the person who is not really ready to act yet. And it's interesting because the research suggests for people like psychiatrists, physicians, social workers, that's not a helpful intervention, is these kind of promises. However, for people who are friends, associates, colleagues, peers, it is helpful. I think it kind of makes sense, is that one group is paid to help people. The other group is doing it out of the kindness of your heart. Not to say that I only help people who are suicidal in my practice because I'm paid to do it. I wouldn't be doing the work if I didn't find it rewarding. But, from a patient's perspective, making a promise to someone who's your clinician is a little different than a person making a promise to a loved one or a friend. And ultimately, really, even just your willingness to listen and to help can rekindle hope. It's amazing when you look at the research, when people who were suicidal had discussed this with someone that they trusted and cared about, how they said, really just talking it out loud with somebody who I loved and I cared for made me think differently, and changed my mind and put me on a different course. So really just being present, and hopeful and affirming goes a long, long way. But again, if the person's willing to go with you to go get help, that would be the number one option. So accessing help. So sometimes people who are suicidal don't believe they can be helped. That's that whole hopeless thing, right? So you may have to do more. So it's, call it, reaching out to them more, saying, hey, I just want to see how things are going. I really care about you. I want to see if you decided to go to that place that we talked about. Again, like we just mentioned, the best referral involves taking the person directly to someone who can help. The next best referral is getting a commitment from them to accept help, and then making the arrangements to get that help. So the person's saying to you, yeah, I promise I'm going to go to the counseling center. I'm going to go there at 3:00 today. And yeah, thank you for helping me make the phone call to get that appointment there. And the third best referral is to give referral information and try to get a good faith commitment that the person's going to engage in that referral, or not attempt suicide. Any willingness to accept help at some time, even if the future is a good outcome. So even if the person says, okay, I'm not ready right now, and I'm not going to kill myself, but I would be ready maybe in a week, then following up obviously with them over that period and helping them get that help at that week would be a good scenario in general. So in terms of what are some NEOMED referrals for mental health concerns. So if you ever had a person on campus, could be employee or student, who was saying, I'm going to kill myself, I plan to do it, and there's nothing you can do to stop me. That's what we would call an immediate threat. And at that point, you'd be calling 911. And they would then, if you're on campus, and then the NEOMED campus police would then come get that person the help that they need. And one thing I would say about the NEOMED campus police, they are trained in the crisis intervention team model, which is an evidence-based practice for law enforcement. The Department of Psychiatry promotes that practice and adherence to that practice. Those folks are trained in de-escalation. They're trained in having a supportive, empathic stance. They work very hard to meet students who are in crisis in a really respectful, empowering way. And you all, I know you're just first years, but they intervene more than anyone knows with students who are thinking about suicide, and are more often than not able to get them to go to the hospital voluntarily as opposed to involuntarily, which really is just a testament to the good work that they do. And they also, so they're just fantastic. We're very lucky to have them as a resource here. Also, if it was a student who is perhaps not in Rootstown area, we have students who live in other places, or staff who live in other places. You can also call the NEOMED police, but report to them that you have a student, or a concern about a NEOMED community member who's living in Kent or whatever. And they can help arrange a welfare check for that student or staff member in that particular precinct or county. And it's called a welfare check. It's something that law enforcement does for people where there's a concern about a suicidal crisis. And then, because most counties in Ohio have CIT trained officers, the NEOMED police would typically ask for a CIT officer. Obviously, you could also call 911 in your county or in your precinct and ask for a welfare check for someone in your county or precinct, and that you could ask for a CIT officer. So that's really when you think about more that kind of like immediate threat. You'd obviously do that for a homicide threat too. That would be a police call. Someone who's saying, I'm going to blow this place up, or I'm going to kill people, or I'm going to kill this person. So those are what we're talking about, your immediate threats. If we're thinking about somewhat of a less immediate threat, so the student who's more saying, yeah, I think about suicide sometimes. It's really hard to shake. I don't know if I would ever do it or not. Um, uh, you could think about 911 in that scenario. Monday through Friday, 8 through 5, you could be thinking about the counseling center and getting them to the counseling center. So the counseling center phone number and email address are right there. And also it's located, their office right outside of the library at A200. So it's really right outside the library. If someone is in a mental health crisis, they don't have to have an appointment. They can just be walked right there and sit in the lobby. And then a clinician will reach them as soon as they can. There's Dr. Dougal's number as well, the director of the counseling center, and her extension is 6484. There's also the suicide prevention lifeline number, 1-800-273-8255 or TALK. That's something you could offer someone who is really more in the scenario of, yeah, I have thoughts of suicide sometimes. I would not act on it, but I do have it. And that's just so they have that accessible, because sometimes things change and things get worse and you'd want them to have that resource. There's also the crisis text line, 741-741. For Ohio, you text for HOPE and then the 741-741. Or the for HOPE is the message. And the reason for the for HOPE is for Ohio, then they collect data on the prevalence of phone calls, the prevalence associated with region and time of year. And it really helps us learn more about the kind of potentially the factors contributing to suicide in a particular region, or the way in which we need to allocate resources based on prevalence and region and time of year. So it's really, in Ohio, can be helpful to do the for HOPE part of that. There's also something called the CARE team, and Chief Miansky of the NEOMED police and myself are the chairs of that committee. And CARE team is nothing that NEOMED invented. It's a pretty common type of group across higher education and other types of large organizations. So essentially what the CARE team is, it's a multidisciplinary resource team. So what does multidisciplinary mean? It means we have a number of folks involved. So there's a chief of police, you have a psychologist, and Callie and I. You have human resources representation, because this is for employees and students. You have College of Medicine, College of Graduate Studies, and College of Pharmacy representation. You have student services representation. You have the counseling center. So it's meant to be a bit of a cross section of the whole campus. Because we all have different information, we all need to share information, and we all have different types of expertise. And essentially what we do, one thing that's really important that you know is that we all sign confidentiality agreements so that we cannot report any student or employee that we're discussing in that team outside of that team. The only instance where we would break that confidentiality is if the person was at imminent risk to seriously hurt themselves or to seriously hurt someone else. Then we would then break confidentiality just like a physician or other clinician would. We have to report things that are an imminent, serious risk to self or others. But short of that, we don't discuss anybody that we are helping in that team. So you will never know if someone has actually been followed by the CARE team. And essentially what happens is that we as a team, we meet monthly, but we meet more frequently if we need to. We would get a referral. So you see the online referral form down there. It can be submitted anonymously or not. So one of you listening, let's say that you have a student that gives you their prized guitar and they're seeming more agitated and distressed than they usually do, right? So what you could do is you could fill out this CARE team form. You could either do it anonymously, so you wouldn't have to disclose your information, or you could leave your information. Either way is good. We say information is better than no information. If you are comfortable providing your information, that's helpful though, because sometimes there's more details we want to get from you. But if not, that's fine too. Obviously, we need to know the name of the person that you're concerned about. You could also just email Callie or myself, or I gave you my cell phone number too, or call us if you had a concern about an employee or a student. So essentially, Callie and I get that referral. We decide, first of all, okay, is this an imminent risk or is it not an imminent risk? Although the care team referral resource is not meant to be for imminent risk, again, that would be a 911 call. It happens sometimes, so we need to act quickly. So we would review it, and if it was an imminent risk, so, okay, we're concerned the student is really seriously considering killing themselves, then we would engage the 911 process. But if it was more like I just mentioned, it's your fellow student that gave you their guitar and they're seeming more distressed, and they're not caring about schoolwork as much anymore. We would, as a team, figure out who on our team has a relationship with that student already. Because what is most helpful is to have someone who already has a relationship reach out to that student. That person with that relationship would then reach out to that student. They would never disclose that there was a referral made on them. They would never give information about the person who made the referral. They'd basically say something like, I'm just making up a name, obviously. Hey, Johnny, I hope things are going well for you. You know, we like to do check-ins periodically with people. I just wanted to see how things are going academically. Would you be open to coming to my office to see how things are going? So it'd typically be just kind of like this warm, soft outreach. And then that person would then get a sense of how that student is doing. And if they were then concerned about them as well, they would then discuss linking them to some type of mental health provider, to the counseling center. And then we would kind of as a team make sure that that student is getting their needs met and only follow them to the point to where we felt like they were then stable or not a concern anymore. Obviously, there's that same pathway for an employee where typically like human resources would reach out to that person in very much the same way. Hey, just seeing how things are going. I understand things have been challenging in your department right now. Just wanted to reach out, see what we can do to help you, right? So it's really meant to be that type of a resource. It's never punitive. Really, the whole idea of this is intervening with an employee or a student before it becomes a full-blown crisis or before things happen to the point where it does become punitive, where people lose their jobs or where people have to, people fail classes or have to leave the university. So really this is meant to avoid all that. And I mentioned at the beginning that, you know, me, myself, one reason why I'm very passionate about this issue is there was a time when I was an undergraduate in the early 90s, where I had serious thoughts of suicide. And there were people who, there was a professor, there was a lab technician who I did research with, and there's a couple of students who just kind of on their own reached out to me and provided hope and empathy, and they intervened before things got way worse, and I wouldn't be here if it weren't for them. So I would never be a part of any team that didn't have that same approach. So this is not punitive. You're not getting people in trouble. Really what you're trying to do is prevent things from getting worse to where people do get in trouble, or just that they don't reach their goals, either employment related or academic related. So that's the care team. And again, you have our referral, our online referral that you can do anonymously or by providing your information. And then you have Callie and I's email addresses there. Really what we're trying to promote here at NEOMED is a culture of caring. Trying to help people not suffer in silence, to reach out to them. So to do that, we really want to notice changes in mood or behavior. You know, like what we mentioned earlier, the kind of red flags. Be willing to ask the question, maybe starting off with something like, you ever had thoughts of like wanting to go to sleep and not wake up? You ever had thoughts of wanting to end your life? Asking those questions, being patient, empathic, and supportive. yeah, I get it. This curriculum and it's so hard. And the fact that things are happening with your family and you're worried about them, it just feels like there's never ending. It's just stress. I get it. That's got to be incredibly challenging. And then saying something like, hey, would you be open to going to the counseling center with me? I'm happy to walk you over there right now. Or what other way can I be supportive of you right now? Normalize their feelings, normalize that life can be hard sometimes, and affirm their courage. It takes a lot of courage to tell another human being that you're suffering. So I say things a lot to people like, wow, it takes a lot of courage to be so open about what's going on. You're really brave. And just normalize their feelings of distress and encourage them to seek help. And just trying to keep them in mind that really almost any effort to persuade someone to live instead of attempt suicide will be met with agreement and relief. The research is pretty clear on that. For the most part, people, and even if it's someone who wasn't thinking about suicide at all, their mood had changed. That population and studies also suggest it was nice to have someone reach out to me. You probably heard some of this new ad campaign around Seize the Awkward, right? The idea of seizing the awkward of reaching out to people and asking how they're doing, and normalize that life can be stressful, and that you're there to be a partner with them in it. So really most any attempts like that are, as long as it's coming from a good place, is going to be met with relief, and really appreciating that you're someone there to support them. For effective support, saying things like, I really want you to live. I'm on your side. I'll walk through this with you. We'll get through this. Get others involved. If you know that they're also close with other people, family, friends, brothers, sisters, pastors, priests, rabbis, imams, physicians, anyone who you know of who's also in their sort of support ecosystem, that you think could be a help, and an ally in this process, to get them involved as well. Just kind of more of that, just being a partner in whatever support strategy they try to go to they're willing to utilize. Following up with a visit. So it's really nice, the person went to the counseling center, they went to a physician, they went to a psychiatrist, and then kind of reaching out to them after that, or maybe the next day, and saying, hey, I was thinking about you yesterday, or I was thinking about you tonight. How did it go there? What are you thinking about continuing to work with them? How else can I be helpful for you right now? How can I be a support to you? And those are just some of the references related to some of the things that I alluded to. So again, thank you all so much for hearing me out. I look forward to meeting with y'all and kind of discussing this, and maybe doing a little practice with it. And we're just all very happy for you to be at NEOMED. We're very happy for you to be a part of our community, and really excited about the opportunity to learn from you all, and to teach as well. So take care, everyone. Thank you.